How to treat inguinal hernia without surgery. Part 3.
Chapter 3. The oblique or common inguinal hernia. Footnote. Hesselbach has called this kind of hernia external, in contradistinction to that which passes to the inner side of the epigastric artery. The term oblique appears to be more appropriate as it denotes the oblique course of the hernia through both abdominal apertures. Ed. End of footnote. The different kinds of hernia are subdivided into several distinct species. Of the inguinal, there are 4. The oblique, or that which takes the course of the spermatic cord in the male, and the round ligament of the uterus in the female. The direct, which passes immediately from the abdomen through the external abdominal ring, so that its direction from the scrotum into the abdomen is not attended with that obliquity which characterizes the former. The congenital, in which the protruded viscus is found within the cavity of the tunica vaginalis. The encysted hernia of the tunica vaginalis, in which an additional membranous sac is formed within that peritoneal sheath. The oblique makes its first appearance at the internal ring in the form of a small tumor, situated about 1.5 inches to the outer side of the external abdominal ring, in a line extending from the pubes to the anterior superior spinous process of the ilium. If its progress be uninterrupted, it proceeds gradually obliquely downwards and inwards in the direction of the inguinal canal as far as the external ring. As long as it remains within the canal, its existence is often not suspected by the patient, because it requires a careful examination to detect it. But to a surgeon, acquainted with the natural feel and appearance of the parts, it is sufficiently obvious. The length of the swelling above the ring will be found the same as the part of the spermatic cord included between the upper opening and the abdominal ring. That is, about 1.5 inches in the adult subject. The tumor next descends through the abdominal ring into the scrotum, here taking the name of scrotal hernia. And being now less confined than before, it forms a distinct swelling, sufficient to awake the patient's attention, who now, generally for the first time, is led to require surgical assistance. As the growth of the tumor, when in the scrotum, is little restrained by external pressure, it increases to an almost unlimited and sometimes enormous size. One of the largest of these swellings which I have ever seen was in a man who was sent to me to Guy's Hospital by Mr. White, surgeon at Lambeth. It reached to the patient's knees. Its length was then 22 inches, and its circumference 32. Another measurement taken by Mr. White, when it had been for some hours strangulated, gave 34 inches for the circumference and 22 for the length. When an inguinal hernia is dissected, immediately under the skin of the scrotum is found a fascia of greater or less thickness according to the duration and size of the tumor. This fascia is given off by the tendon of the external oblique muscle above the abdominal ring. In general, it appears little more than a condensed cellular membrane, but I have seen it in old hernia as dense as the fascia that covers the muscles on the outer part of the thigh. Footnote. Scarpa, although he has alluded to this covering under the name of aponeurotic web of fascia lata, has not given a separate description of it in his plates, and leads us to understand that the external ring is defined and free from any extensive adhesions to the exterior envelope of a hernial sac. This may perhaps be owing to his thinking this covering as not deserving a separate description from the Cremaster. There is, however, an evident anatomical distinction between them. The Cremaster may be seen coming from under the edge of the ring, free from any close attachment to the margin of the tendon. The superficial fascia, on the contrary, comes off as it does in the healthy state, from the edge of the ring, and forms a covering to the Cremaster, sometimes cellular, at other times thin on the forepart, and dense on either side. And in hernia of long standing, it frequently acquires such density as to appear to be a prolongation of the external oblique tendon. In the operation, it should be borne in mind that the margin of the ring is not always distinct, being often obliterated by its junction with the superficial fascia. Mr. Lawrence bestows the following notice on the fascia. Some tendinous fibers, derived from the aponeurosis of the external oblique, where it forms the lower opening of the abdominal canal, may be occasionally seen in this external investment, Cremaster. The pressure of the tumor occasions a considerable thickening of the parts in old herniae, where several distinct layers may often be recognized. See plate, page 172, opposite ed. End of footnote. Under this fascia is the Cremaster Muscle, which forms another covering to the hernial sac. For this muscle, in passing through the inguinal canal, is united both to the fascia and to the sac. It is easily separable from both, however, by dissection. This muscle becomes much more extended and thicker in hernia than in the natural state. Footnote. In conformity with the laws which regulate the increase of muscular fiber in proportion to the demand, the cremaster becomes extremely thickened, the fibers sometimes acquiring the width of the finger. The cellular membrane circling the fibers in a healthy state not only yields from the pressure, so that the fibers of the muscle appear disgregated, but also become thickened, and thus, on the anterior and lateral parts of the tumor, a very dense covering is produced, which adheres both to the hernial sac and superficial fascia, especially to the latter. This covering is by far the strongest in the dissection of an oblique hernia. Ed. End of footnote. When the fascia and the cremaster muscle are removed, the proper hernial sac becomes exposed to view. This is thinner than the former two coverings, but somewhat thicker than the peritoneum, from which it is immediately derived. Many writers have represented the sac as much denser than it really is, mistaking the two above-mentioned coverings for the sac itself. Footnote. It is clearly ascertained by the dissections of modern pathologists that the sac differs but little from the healthy peritoneum. The older writers used to consider it as being always thickened. When such change takes place in the density of the sac, it must be regarded as an exception to a general rule. Ed. See plate. End of footnote. Behind the hernial sac lie the spermatic cord on the upper part and the testicle on the lower, so that the sac is situated between the cord and the cremaster muscle, anteriorly to the former and posteriorly to the latter. The direction of the hernia above the abdominal ring is obliquely upwards and outwards towards the spine of the ilium, the same as that of the spermatic cord. Above the ring, the hernial sac is covered by the tendon of the external oblique muscle. The spermatic cord is still behind it, and farther backwards are the tendons of the internal oblique and transversalis muscles and the fascia before mentioned. Footnote. There is no part of the anatomy of inguinal hernia which has so important a claim on the attention of the practical surgeon as the connections of the hernial tumor between the two abdominal rings. It is not, perhaps, affirming too much to say that, in by far the greater majority of strangulated oblique herniae, the cause of strangulation will be found at the inner ring. Such a statement will, I apprehend, accord with the experience of those who have frequently operated in this disease, and will also show the importance of a correct understanding of the structure of this part. When a hernia is situated in the inguinal canal, or making its appearance at the external ring, the obliquity of the canal is preserved. In the course of time, however, by the constant pressure of the tumor, the internal ring is forced inwards towards the pubes, till it meets the unyielding tendon of the transversalis muscle. This tendon, being attached to the fascia transversalis near the pubes, becomes raised over the hernia in the form of an arch, the muscular fibers first passing horizontally over the tumor, while the tendon dips deeply to its inner side to blend with the fascia transversalis. In the dissection of a hernia, this tendinous loop or band can readily be felt by passing the finger up through the external ring, and will demonstrate one cause of a hernia becoming strangulated at the internal ring. It has been a matter of dispute whether the sac receives a covering from the process of fascia sent down upon the cord from the outer margin of the inner ring. In the dissections I have made to ascertain this point, I have found that the peritoneal sac is covered by a thin layer of membrane continued from the edge of the fascia transversalis, but preserving so little the character of fascia as to be of little importance in a practical point of view. Cloquet observes, Les hernies inguinales externes descendent d'abord dans l'étonnoir membraneux du fascia transversalis. Scarpa attaches considerable importance to the cellular covering found between the cremaster and sac. He has described it in his second plate as forming a distinct layer enveloping the hernial sac, under the appellation of latella l'osse esteriore del peritoneo la quale circondo et accompagna il sacco herniaro dal di dentro del ventre seno nel fondo dello scroto. Questa cellulosa nel erni scrotali di mediocre volume mantiene la naturale sua mollezza e flessibilità. Nesi presente sotto altra forma che quella d'una suffice spagnosa sostanza, interposta fra la guaina del cremaster ed il sacco herniaro fatto del peritoneo. Page 19. In fat subjects, a quantity of adipose structure situated at the internal ring is not unfrequently protruded before the sac, and appears to give it a distinct covering. But in the majority of inguinal herniae, this cellular membrane, alluded to by Professor Scarpa, differs so little from that which unites the other coverings as not to merit any particular notice, except in the instance of fat presenting itself under the cremaster, when, as in femoral hernia, it is liable to be mistaken for omentum. The course of the epigastric artery, in regard to the neck of the hernial sac, is uniform in all cases of oblique hernia, notwithstanding the opinions of some respectable authors to the contrary. The only difference, if such it may be called, in the course of this vessel in different subjects, exists in the greater or less curve it forms in its passage around the back and inner part of the hernial sac. When the hernia is large, of long standing, and by pressure has destroyed the obliquity of the inguinal canal, the curve of the vessel becomes considerable, forming nearly a semicircle with its convexity towards the pubes. Ed. End of footnote. At the internal ring, the sac communicates with the cavity of the abdomen. This part is called its mouth, and is generally, though not always, its narrowest dimension. Between the mouth of the sac and the symphysis pubis passes the epigastric artery. This vessel runs, in some degree, under the sac and along its inner side. There is no vessel of importance above the mouth of the sac, nor externally, that is, between it and the spinous process of the ilium. See plates. The above description of the situation of the hernial tumor, in regard to the abdominal openings, applies only whilst it remains of small size. For when a hernia has existed a considerable length of time, and has carried with it a large portion of the abdominal viscera, the constant pressure dilates the parts in each direction, extending the opening through which it passes from the abdomen slightly towards the spine of the ilium, but more especially towards the symphysis pubis. Hence it is that in old and large herniae, the internal ring is brought to be almost in contact with and opposite to the external abdominal aperture. This difference will be distinctly seen in the plate which represents a hernia on each side. On the right, a small one, in which the mouth of the sac is at the greatest distance from the abdominal ring. On the left, a large hernia, the mouth of which approaches very closely to the ring. This change by gradual enlargement, however, makes no alteration in the relative position of the epigastric artery, except in giving it a greater curve, for its course is still on the inner side of the mouths of the sac. It has been stated that the hernial sac in its descent is anterior to the spermatic cord. This is its most frequent situation, but varieties occur in this respect which the surgeon should keep in mind during the operation. Thus, the cord is sometimes found separated, and the hernial sac protruded between its vessels. This circumstance is represented in Plate 5, taken from a preparation in my possession, in which the vas deferens is seen passing on one side of the sac, and the spermatic vessels on the other. In another case, which I shall afterwards describe, I met with the spermatic artery and vein passing before the sac, and the vas deferens behind it. It has been stated, but this I cannot give from my own observation, that the whole of the cord is sometimes anterior to the sac. Footnote. It has been asserted by Ledras and other surgeons of repute that they have met with the whole spermatic cord on the forepart of the hernial sac in operating on large herniae. Of this, however, I am disposed to require more conclusive evidence than the imperfect dissection and separation of the tunics of a hernia during an operation can afford. In Mr. Shepherd's case, it appears that the operator was under the apprehension of having divided the whole of the cord, whereas dissection afterwards proved that the vas deferens was the only vessel found on the anterior surface of the sac, having been separated from the artery and veins. If it happens that the entire cord is ever found anterior to the hernial sac, it cannot proceed from the pressure of the tumor, and it is difficult to conceive how it can arise from any accidental variety in the relative situation of the spermatic vessels at the orifice of the sac, as an examination of the natural course of these vessels behind the peritoneum will show. The most frequent variety met with is that in which the tumor has forced the vas deferens to its inner side, 2 instances of which are delineated by Camper, and 2 also described by Mr. Hay. And as the tumor acquires bulk, this vessel gradually advances before the lower part of the sac. A careful operator will bear in mind this frequent change in the situation of the cord, and will check his hand on finding a vascular band under his knife. But as there is no necessity for opening the lower part of the sac, there is but little risk of wounding the spermatic vessels, which are rarely found, as Scarpa has justly observed, on the fore part of the sac, so high as the external ring. The late Mr. Hay, in operating on an inguinal hernia, divided the vas deferens, which has induced him to advise the free division of the scrotum, before the other coverings of the hernia are opened. Scarpa has also detailed a case in which he wounded the spermatic artery in puncturing a large hydrocele, the same change having taken place in the situation of the vessels as occurs in large herniae. Ed. End of footnote. For the following case, in which the vas deferens was situated on the fore part of the tumor and unfortunately divided in the operation, I am indebted to Mr. Shepherd, surgeon at Worcester. Worcester, December the 5th, 1814. Dear Sir, I have taken the liberty of sending you an account of a case of scrotal hernia that occurred in this neighborhood about 3 weeks ago. The parts sent are precisely in the state I found them, having been examined after death by the operator. The particulars of the case were as follows. The patient had been subject to hernia for some years, and during sleep he awoke with symptoms of strangulation. The usual remedies failing to afford relief, he submitted to the operation about 40 hours after strangulation commenced. The tumor was very large, and in its descent had separated the spermatic cord. The artery and vein passed down on its inner side, the vas deferens on the anterior part, which latter vessel was divided in the operation and noted by a person present. The man died in about 24 hours after the operation. His body was then hastily examined, and a portion of the vas deferens removed, which I have supplied by a piece of tape. A few days afterward, it was reported to me by a gentleman present at the operation that the whole cord had been divided by the operator, but without any hemorrhage following. Knowing that varieties of this kind were rather unusual, and not being able satisfactorily to account why the artery did not bleed if divided, I felt a strong desire to ascertain whether this was the fact or not, and having obtained possession of the body, I found them as before described. I am aware that the cord has frequently been found separated by the descent of the hernia, but rarely, I believe, precisely in this manner, the spermatic vessels most commonly having been found on each side of the tumor when any division has occurred. Though I rather think Mr. Hay has given a case where the vas deferens crossed over the anterior and inferior part of a hernia that he was operating on, and which he also unfortunately divided. Knowing the great interest you take in everything at all elucidating the subject of hernia, I thought this case might be worth detailing. Your obliged and obedient servant, James Shepherd. The inguinal hernia is very generally piriform, small towards the ring and enlarging as it descends. It occurs much more frequently on the right than the left side. The symptoms and circumstances whereby this disease may be distinguished from other tumors with which it is liable to be confounded are the following. First, when the patient is desired to cough, the tumor becomes immediately distended, owing to the pressure of the abdominal muscles forcing down into the sac more of the viscera or their contents. Secondly, the patient can usually state from his remembrance that on the first appearance of the tumor in the groin, it used to return into the abdomen when he was in a horizontal posture, and to reappear on standing erect. though circumstances may have long prevented this symptom from continuing. Thirdly, the progress of the tumor is described by the patient as having commenced at the groin and proceeding gradually downwards into the scrotum. Fourthly, when the tumor contains intestine, it is elastic and uniform to the touch, and on being pushed up into the abdomen, it returns with a gurgling noise. But when omentum is contained, the tumor is less equal on its surface, receives an impression from the fingers, is heavier than in the former case, and is not attended with any peculiar sound when returned into the abdomen. Most commonly, however, both intestine and omentum are the contents of the hernia, a circumstance which impairs the accuracy of any very nice distinction by the touch. Though still, on pushing back the contents of the tumor, the presence of intestine, which returns the first, will often be indicated by the gurgling noise, whilst the more solid omentum may be felt going up after it. Lastly, the functions of the viscera are somewhat interrupted. Eructations, nausea, constipation, colic pains, and distension of the abdomen occur, and pain is produced by violent exertions, coughing or sneezing. These are the symptoms that generally give the patient some suspicion of the nature of the complaint. However, there are several diseases of the groin and scrotum with which hernia is liable to be confounded, so that there are few surgeons who have seen much of hernia who have not frequently witnessed mistakes made even by medical practitioners, which have led to the application of trusses in diseases where they are not only useless, but even productive of much injury. The reputation of the surgeon and the safety of his patient require of him a very accurate attention to this point. A hydrocele of the tunica vaginalis testis resembles hernia in its form, but may be distinguished from it by the following marks. The hydrocele begins to form at the lower part of the scrotum, and gradually extends towards the ring. It also involves the spermatic cord and testis, so as to render them with difficulty distinguished by the touch, whilst in hernia they may, in general, be readily felt behind the tumor. Hydrocele gives a fluctuating feel when struck with the finger, does not become dilated when the patient coughs, and appears semi-transparent when a lighted candle is held by its side. I have seen cases of hydrocele, however, in which there was unusual difficulty in deciding upon the nature of the complaint. When it becomes so large as to extend upwards through the abdominal ring to the abdomen, the form of the tumor is precisely the same as that of hernia, and it even dilates when the patient coughs, owing to the sudden pressure upon that part of it which lies above the ring. The transparency, the fluctuating feel, and the observed progress of the swelling from below upwards are then the only distinguishing marks. A tumor sometimes appears in the scrotum, which descends in the erect posture, returns when the body is recumbent, distends upon coughing, fluctuates, and is transparent. This disease is a collection of water which runs backwards and forwards between the cavity of the abdomen and that of the tunica vaginalis, owing to the opening of this membranous sheath never having been closed. When this disease is complicated with ascites, it becomes distended to an enormous size. It is readily distinguished from hernia by its transparency, which may always be observed. Water sometimes collects in a cyst upon the spermatic cord, forming a hydrocele of the cord. When it is placed entirely below the ring, its want of connection with the abdomen readily distinguishes it from hernia. But when it passes within the ring to the abdomen, some difficulty occurs in understanding its nature. If, from its situation, the transparency cannot be examined, and if the fluctuation is not very distinct, a surgeon should be very cautious in operating on such a tumor. The following case occurred to me. I was desired to see a boy, a patient of Mr. Clark, surgeon in the borough, who had a tumor which extended from the upper part of the scrotum through the abdominal ring along the cord to the abdomen. The lad's father was anxious for the removal of the disease, but on examination it did not project sufficiently to enable me to judge whether there was either fluctuation or transparency. However, as it interfered with the boy's usual occupation, I resolved to cut down upon it with extreme caution. When I had reached by incision the surface of the cyst, I found the spermatic vessels running upon it, and was obliged to open the cyst by its side to avoid these vessels. The cyst contained a portion of the small intestine. everywhere adhering to its inner surface, which had prevented the return of the bowel into the abdomen. The vas deferens could be discerned behind the sac, so that this was a hernia, the sac of which had insinuated itself between the spermatic blood vessels and the vas deferens. Nothing but great want of attention can cause a hernia to be confounded with an enlargement of the testis. This latter is sufficiently distinguishable, not only by the absence of the symptoms characterizing hernia, but also by certain positive marks by the form of the gland, which is retained under morbid enlargement by its weight, by the pain with which it is generally accompanied, and by that peculiar and intolerable sensation always produced by pressure upon this part. Hematocele, or a collection of blood in the tunica vaginalis testis, is of the same form with hernia, and liable to be confounded with it. But the firmness of hematocele, the redness of the skin with which it is accompanied, its refusing to dilate under coughing, and a freedom from swelling of the spermatic cord of the abdominal ring, which is generally the case, will usually afford the means of distinction from hernia. But of all the diseases which are mistaken for hernia, none is so much so as the varicocele, or enlargement of the spermatic veins. Often have I known persons, even the children of medical men, wear trusses for a supposed hernia, which they complained did not fit, gave them pain, and could not prevent the descent of the tumor, when, upon examination, I have found that the disease was this enlargement of the spermatic veins. Varicocele has indeed many of the characters of hernia. When large, it dilates upon coughing, but not otherwise. It appears in the erect position and retires when the body is recumbent, and it is first observed near the external ring. The only sure method of distinction with which I am acquainted is this. Place the patient in the horizontal posture, and empty the swelling by pressure upon the scrotum. Then, putting the fingers firmly upon the upper part of the abdominal ring, desire the patient to rise. If it be hernia, the tumor cannot reappear as long as the pressure is continued at the external ring. But if it be varicocele, the swelling slowly returns with increased size, owing to the return of blood into the abdomen being prevented by the pressure. The diagnosis will also be materially assisted by the peculiar ropey feel of a varicocele, which gives the idea of a bundle of cords being attached to the outer part of the testicle. There are, however, some cases of a complicated nature which demand much judgment and accurate discrimination. For instance, hernia is sometimes complicated with hydrocele of the tunica vaginalis, and sometimes the sac contains omentum, adhering to its upper part, and a collection of water below. If the adhesion of the omentum is complete, there is no danger of attempting the cure of the hydrocele by injection. However, if the case clearly appears to be of this kind before operation, it is best to use the method of incision. The late Mr. H. Klein met with the following case of this kind at St. Thomas's Hospital. John Ruby, a sailor, aged 30, was admitted in St. Thomas's Hospital on Tuesday, January the 3rd, 1815, for a scrotal hernia, which he had not been able to reduce since the Friday preceding. He gave the following account of himself. When he was about 9 years old, he had a cold, accompanied with a violent cough, and while in the act of reaching down the hatchway of a vessel, he was seized with a fit of coughing that brought on symptoms of hernia, for which, by the advice of a surgeon, he wore a truss some years. But finding some inconvenience from it, he applied to a man who advised him to leave it off entirely, if he were not cured of the rupture by the time he was 20 years old, which he did, and found no remarkable inconvenience from it till the Friday preceding his admission to the hospital. He then found that he could not reduce it, as he had always done before when in a horizontal posture. The patient complained of hiccup, and could not bear the slightest pressure upon the abdomen. Pulse 150. The usual means for reducing strangulated hernia having failed, recourse was had to the operation, which was performed by Mr. H. Klein. On making an incision into that which was supposed to be the hernial sac, a fluid similar to that of hydrocele escaped, which it afterwards proved to be, for it was the tunica vaginalis which had been opened. On dilating this opening a little, a tumor presented itself, which was afterwards found to be from 1/8 to 1/4 of an inch thick, which being dissected through, A fluid, resembling the first in colour, but of a fetid smell, came out. This tumour was found to be the tunica vaginalis of the cord, but much altered from the natural appearance of tunica vaginalis by a quantity of thick lymph that had been effused, which gave it the appearance of India rubber. The intestine had adhered firmly to the adjacent parts, and the stricture was divided with the finger. Mr. Klein thought it not advisable to attempt to break through the adhesions so as to return the intestine, lest it might bring on a dangerous degree of inflammation. The wound was superficially dressed and the patient put to bed. He complained of some pain in the abdomen, for which he was ordered a fomentation. He soon became convalescent and left the hospital quite recovered, wearing a bag truss to support the scrotum. Sometimes the case is still more complicated. A man of the name of Freeman, late a patient in Guy's Hospital, had a diseased testis and hydrocele on each side, the latter of which was open to the abdomen, together with a large hernia on the left side and a smaller one on the right. I have met with 2 instances of steatomatous tumours being mistaken for hernia. One of the cases was a boy brought to me for advice respecting it. The other was a man of about 60 years of age, whom I examined after death, and who had worn a truss for some years by the direction of his medical attendant, under the idea of his having an omental hernia. The tumour was soft and felt like loose omentum, and was situated over the abdominal ring, exactly in the situation of an inguinal rupture. Vide plate 11.